Thank you. So I know I'm standing between you and lunch, so we'll try to make this entertaining. So I just want to put some context around this. I'm with UC Health, which is part of University of California, the whole university system and labs. But UC Health is comprised of the 5 medical centers, medical schools, and they're up here: Davis, Irvine, UCLA, San Diego, UCSF, and Riverside. So it's 5 individual health systems up and down the state, plus all of our medical schools and ancillary health programs and our affiliate hospitals. So that's the side that I'm on, and this is what we're trying to do, is implement UC Health's telehealth vision. Let's see which way I do this. Is this going to work? How about just enter? What? Does that go back? Does it hit back? How's the back? Okay. Okay. So, our problem statement, but really I was rethinking this, and it's really why embark on telehealth. We know that there's a big demand for virtual care, patients, employers, payers. It's large, it's growing. There's a demand for more access and improved access to clinical services by the same groups. In mental health, we know that there's a big unmet need up and down the state. Competitors are moving into California. Mayo is in there right now. Cleveland Clinic is moving in. I think Hopkins. And there's a number of for-profit companies that are now partnering with nonprofits to offer telehealth services. So American Well has been partnering, Grand Rounds, Live Health Online, which is part of Blue Cross Blue Shield. And as a system that runs up and down the state, we believe that we should be really implementing virtual care to all of our patients. Currently at UC, and I really want to thank the previous speakers because they really validated a lot of what we've been talking about and dealing with here. You know, each campus has their own telemedicine offerings, but they're really stuck in sort of what we're calling boutique offerings. It's very hard to get them off the ground and to make big impact, and it's a bit of a horse and cart program. It's how much do you really want to put into it, and an investment do you want to make? And as we all know, healthcare is not technology. We are not nimble. So it's very, very difficult. In addition, there's capacity problems, there's specialty issues, there's synchronous versus non-synchronous, there's laws we have to meet. The customer experience is very variable because it depends on what kind of resources the institutions are putting into telemedicine. And of course, the value proposition varies by campus leadership. And really understanding the value of telemedicine, and there's one thing that I wanted, and this conversation, the conversations today are really driving home. We know that intuitively telemedicine is the right thing to do. I mean, I think that everybody believes that it's a great tool. It really increases your reach and your outreach. But as we all know, it takes 17 years to implement a new way of doing something in healthcare, right? It took 17 years to get door-to-balloon time to be down to an hour, across the board, and that becomes practice. I wouldn't let that stand in the way. Even though the uptake is slow, I don't think that's a reason to not do telehealth. I think that this is something we really need to be looking at and we need to be doing. It's the only way we're going to be able to provide good health care. So a couple of us got together and we proposed a UC Health unified telemedicine entity establishing system-wide telehealth access, integrating all of our medical expertise that was seamlessly available to the patients, referring providers and payers, using telemedicine and other technologies that aligns with our mission of clinical care, research, and education. And it was pretty audacious. And we proposed this to leadership, and leadership said, go do the due diligence, do the research, see what you can put together. So we did, and that's what we're in the process of doing right now. I'm not going to go through what's out there. You guys have seen the other slides. You can read these. We know that the key drivers around this are improvements in technology, pressure to decrease costs, and drive care that is much more consumer friendly, where there is a demand for people to be able to access in a timely manner health care. We know the risks are the regulatory environment, pricing pressures, and we do move way too slowly. Here's a little bit more about what the projected revenues are in telemedicine. We called out telepsychiatry, and I'll talk to you a little bit more about why we're focusing in on telepsychiatry as a start. So for us, for UC, we have a big national and international presence. So for us, that is our potential market. The state, nationally and internationally, we have full geographic distribution. We do a lot of international work as it is with second opinions. We bring in patients internationally, and we get approached a lot by companies because of being in Silicon Valley, and a lot of newer companies who are self-insured, and they're taking on more risk. They want us to partner with them. So our proposed system would be access to all of UC Health from anywhere and through a single portal. So by that I seriously mean 1-800 dial up UC Health, and you can have our specialists through any of our medical centers through a single portal. We think that that's going to be the most efficient, cost-effective way to be for patients and providers. Now, the reason why we think that we should be doing that is our sweet spot really is tertiary quaternary care and some secondary care. UC is not known for primary care. We're really known for our specialty care. We have a lot of deep domain expertise. And we don't think, and we're hearing it from our providers, they're not being leveraged. So we feel as though the thing that we can offer that differentiates us is offering deep domain expertise type care in a telemedicine platform. Why do we think that now's the time? Demand. Consumers are very comfortable interacting in different ways. They're very comfortable with electronic and virtual engagement. Employers are looking for efficient, lower costs. We are taking more financial contracting risk. And along with us, because we're a self-insured employer, so are a lot of other employers. We have a reputation that is exciting to people who want to access. People want to be able to come to UC. When I go out and I talk to people about being able to access our specialists from a single point, people get excited about that. It's very attractive to payers, to employers, and to investors. Okay. So our telehealth pilot program overview is to develop this system-wide telehealth program aimed at leveraging our individual campus expertise and best practices in a scalable manner. We're going to leverage and put in shared services. So all of our, I call it back office, billing, admin, credentialing, contracting, et cetera, is all going to be done through a one portal that's going to be shared. But one of the things, and Siggy, I think, talked about this, we don't want to do it on a shoestring. Healthcare and hospitals, they really tend to do these things on a shoestring. We went in, after we did a lot of our due diligence, we said, look, we need a 3-year runway. We're going to give you a business plan. We want a 3-year runway. We want to take out a loan. Here's what we think it's going to cost us to get this up and running for 3 years. We need the medical centers to do a loan guarantee or an outside investor. And we think that after we get those things in place, and we're in the process of doing that. We've got, we're 90% there on getting the loan. We're 50% there on getting the medical centers to do the loan guarantee. And we think within 6 to 12 months, we'll be able to go live with our first product. So our go-to-market strategy is to start small and then expand. We're going to start with Tele-mental health because we've been doing a lot of external scans of the external environment, and that is our minimum viable product. We have a lot of engagement with all of our psychiatry departments. All of our psychiatry departments have training programs. They're all interested in doing training in telepsychiatry. We have the experience in a lot of different areas of telepsychiatry, whether it's medication management, things like eating disorders, adolescent psychiatry, psychiatry with chronic conditions, and depression as a comorbidity because of chronic conditions. We've got all kinds of different specialists within that department. We don't compete with each other, which is really important. And they really are interested in working together and sharing and building this department. So that's why we're going to start, we think, with psychiatry. It is a huge need. We've been told by our payers that it's a gigantic unmet need, especially for psychiatrists. And we have a big student health population, which is also, it's an unmet need for them. So we think that that's really the way to get started. With telemental health, we also feel that our operating costs are fixed, and our operating costs are going to decrease as we continue to add specialties. So I don't need to read all this, but really what we're going to do is we're anticipating that within 12 to 24 months of launching our first specialty, we'll be able to launch 2 more additional services. And again, I think it's all in the deep domain. So I'll give you an example. A couple things that we think are going to be really viable are things like telepathology. Pathology, especially super specialty pathology, is in great demand, and we have a lot of that available to us. And the reason why it's in great demand is because of all the new immunotreatments and specialty treatments. The treatments for these patients is very, very expensive. The payers are coming to us, and they know that the patients now, we can drill down, and the patients who are going to be the most receptive are nuanced. You need to have that deep domain pathology understanding and expertise so that you can make sure you're matching the right patient to the right treatment, especially in these very expensive treatments. That's something that we'll probably go out as one of our second or third specialties, that the next ones. But there's also a big need internationally for that. So we do a lot of international telepathology right now. Our barriers, our internal competition. I mean, all the UCs, in many cases, they compete with each other. We're trying to at least get them to co-opetition. Availability of physicians to dedicate time. Now, one of the things that we're asking for in that 3-year runway is we are going to pay the physicians. We don't want people to just have an hour here or an hour there. We really want to get a structured practice in place. So part of our loan includes paying physicians for their time up front. We're going to have physicians ready, I think, before we have patients who are going to be available. But we need, especially with telepsychiatry and certain things, 24/7 coverage. We're going to make sure that we have that in place. Billing and operating costs might be higher. The funding of for the project, we may not get everything that we need. And then acquiring the customer base, because there has been slow uptake. Competition for us is other health systems, the for-profit entities, urgent care centers and minute clinics. There's new potential entrants, like I told you about Mayo and Cleveland, the for-profit entities, and the app developers. Our differentiation, that we think, is our reputation. We're cutting edge in research and specialty care. We have a big reach. We have a big supply of providers, and we're constantly producing more. And we have a lot of deep domain expertise. So revenue streams for us would be in the terms of service contracts, for instance, 5150 ED and telestroke coverage, payer contracts for services, international contracts, and per member per month contracts. Pricing models, they will be structured to cover overhead. It'll vary by specialty, and recurring revenue, all revenue is potentially recurring, which is sort of don't take no for an answer. For us, our immediate next steps are choosing vendor partners, contracting with existing staff, IT integration, and establishing scheduling and billing systems. Now, for our IT integration, we have been working with our CIOs across the system. As you know, the UCs are all on Epic. Whatever we choose would have to be obviously Epic compatible, and then we'll have to be able to build in our contracting with existing staff hiring, but we've already been told by some of our physician leaders that if we're willing to pay for the hires, they're willing to do the hiring, so we will be placing physicians at the different campuses. And then the scheduling and billing, that'll be on the back end, and that'll be UC Health-wide. And that'll be something that's new. We haven't really done this as a UC Health. We have very few things that we've done UC Health. Now, one of the things that we did do is we got cross-credentialing established so that we have providers now, we have a policy in place for our providers to provide telehealth services in their specialty at all the other. If you're credentialed at one of the UCs, your credentials for telehealth services will be accepted at the other UCs for telehealth services. So we did get that built in. That was early on, and we were able to get the med staffs to all agree to putting that in place. That's it. Questions? No, everybody's hungry.
I'm wondering if you're looking at also incorporating. I was talking to somebody from Kaiser the other day, and they were saying that they were using telemedicine in areas that wasn't covered by Medicare. Is the UC system looking at that too, or is it through their Canopy Health, or what's the thoughts with trying to?
No, we're looking at everything. So yeah, definitely with other payers. We will have contracts. We expect to, when we open the doors for telehealth, we expect that we will have contracts in place with the payers who are sending us patients now, who cover our patients now.
So whether Medicare covers or not, it's not a defining factor.
No.
On the vendor selection, what's your top criteria? Like, how do you approach vendor selection? What are the top 3 things you're looking for at vendors? And absolutely not somebody who's doing this.
There's some criteria. Number one, we would love to have one vendor who can help with all the back end, the scheduling, the billing, providing call-in services, call center services, and that can be integrated with Epic. Those would be the things that we would want to do. We don't want to necessarily. I'd like to be with a company, a vendor, have a vendor partner that's not necessarily tied to a payer. So I'll leave it at that.
So in terms of, you had mentioned, which is kind of incredible, and I live in the Bay Area, so I know the health, the UC system. So do you have a unified, shared services for provider data management, like credentialing and all of that across all the different UCs, or is it different solutions?
No. So each of our providers is credentialed at their home entity, wherever that is. What we have is an agreed, across all our credentialing offices, is an agreed upon policy that they will accept your credentials if you're at UCLA and your credentials are active and you're in whatever, psychiatry.
Right.
Your credentials as a psychiatrist will be accepted at the other UCs. We'll just, send the licensing information around, the credentialing information around. You'll be accepted at the other UCs to provide telehealth services. The reason for that is that we need to be able to make sure that our telehealth providers can access all the charts.
Right.
And so that the reason for doing that is so that you can access a patient chart no matter where that patient is and no matter where you are.
I guess my more drilled down question is from a vendor perspective, similar to using Epic at all the different facilities, and you have care everywhere so they can all communicate with each other.
Right.
Do you have a single vendor for credentialing across the entire UC system?
No.
You don't?
No.
We'll have to talk.
Okay. Well, I would like to have that.
Hi, thank you for the talk. You mentioned that at all of the various UC systems, there's currently different initiatives that are being done in telehealth. And I'm not sure if you mentioned this and I missed it, but is all of the set of things that are currently being done at each individual system, are those going to be rolled into this initiative? Are those going to be separate, and sort of how will it be going forward with unified versus system-specific telehealth priorities?
So we don't really want to be in the business of competing with programs that are out there that are successful. We'd like to add to them if they're interested. But if someone says, you know what, we're really happy doing our own little thing in this specialty area, we don't want to play in the sandbox with everybody else, that's fine. What we're trying to do is bring in telehealth offerings that haven't been offered at all of the medical centers. So for instance, telepsychiatry, the way that we're envisioning it, telemental health, hasn't been done in a big way. In this way, and we're beginning to recognize that the only way to be able to bring in some new revenue on a large scale is to do something like this so that we can leverage capacity. So for instance, we have a lot of military installations. A lot of Navy is down in, is in San Francisco, not in San Francisco, in San Diego. Those are big contracts. UC San Diego can't handle that whole contract. That has to be spread out. Same thing with prisons. So there are a lot of big payers out there who would love to come work with us if we can give them if we have the capacity. So those are the things that we're envisioning. We're envisioning that we're going to be a value add to the medical centers doing this, that we're going to be bringing in new revenue, new volume, new patient volume, and offer another venue for training, quite frankly.
You talked a little bit before about, thanks. Thanks. And thank you for the talk, Karyn. You spoke about going to self-insured companies. I'd like you to talk a little further about that and how you plan on getting employees to take advantage. I think 96% of all large employers now use telehealth, but the adoption is still quite low. How do you plan on more proactively getting them to participate than waiting for them to hit the call center? Thank you.
So a lot of those people want to come to UC. I mean, quite frankly, we've got a reputation, and people want to be able to get in there. So offering telehealth is a way to give people access into UC, even if you're geographically, if you're in Bakersfield or something. Offering telehealth gives you a way to build a relationship. We think that being able to offer telehealth to those employers, first of all, we can work with them on sort of the risk sharing, because they're self-insured employers. So there's a lot of different creative contracts that we can put in place with them. And we think that also the telehealth will give people, a lot of employees, an avenue into UC. So we'll roll out, one specialty after another. There's also specialties that we have that, for instance, fetal surgery. We have one of 4 fetal surgeons in the country. So we think that being able to have that in your backyard, those types of services bring in other patients.
Right, and just to follow up to that, accessibility, I get where you're coming from completely. I'm talking about the fact that there's a low adoption rate, period, and since self-insured companies, like other companies, are looking to drop health costs and manage populations, I guess my point was more along the ends of being able to help them solve more than an accessibility issue. A bottom line issue, and saying, listen, you've got to get your employees into this, at least for an initial consult, and here's why, and maybe sort of being a partner with them, as it were.
Yeah, I think there's a mutual incentive opportunity here. I actually also believe, too, that this is so new, and what we're doing here is so new. We can be as creative as we want to be. I mean, there's no rules here. As long as we're not breaking any laws, there's no rules to what we can do, especially as self-insured employers, and we continue to take on risk. So if we're willing to take on risk, we need to be able to, share the gains as well. And I think that we have an opportunity to really be very creative and create incentives for these employers to come work with it. A lot of it is that it's just an extra benefit in some cases.
Thank you, Karyn.
Are you looking at a model that's just intrastate, or you have more grandiose plans to leverage the UC system internationally?
And we're very grandiose. We would like to be able to do that. And actually, international might be easier than going over state lines in some cases, quite frankly.
On that note, what are the issues that internationally make it easier to get a second consult?
Yes.
What's the legal framework for that?
It depends on the country. It depends on the system that's in the. We do it in the Far East, now. We've done some with South America, some with Central America. It really it depends on what we're, what it is that we're working on.
But do you have any U.S. regulations regarding that?
No. I mean, if a patient, as far as I know, there are no regulations, and quite frankly, it brings patients in, Anything else? One more.
For specialists, you talk about people main and the specialists that you have on staff. Do you have any framework for other specialists that are out of state that may have a patient presents to them they never have? They've gone to morbidity, mortality. They do the M&M conference with their local specialist. They still need that. Has anybody ever seen this? Would your specialist be open to like a morbidity, mortality round table to discuss a particular patient to get them to the right individual that may have seen something that's very rare?
I think if the opportunity was there, I don't see why they wouldn't want to do that if they got, especially if there's a payment model in place. I'm sure that they probably do it informally anyway, people who know their friends and call people in other states. I mean, you read about that all the time. I think that would be a great idea to participate in roundtables. I'll give you an example. One of the reasons why we thought that this made sense from a system point of view was that I was talking to one of the hospitalists at one of the medical centers, and he's very forward-thinking, and he said, I was having a conversation. There's no way for a specialist to consult with a super specialist at another UC medical center formally and get paid for that. So the example that he used was a rheumatologist had a patient who had lupus, and the patient was really out of control, and there was a lupus specialist at another UC. And the only way that they could do it was to really do a curbside consult, but that person doesn't get paid, and that person can't help manage that patient. And so what we're trying to do is build in a system so that they could leverage each other in something like that in a more formal way, where that lupus specialist could really be engaged with that patient if it's necessary, or it just becomes an electronic consult. But either way, everybody gets paid and recognized for their contribution.
Can I ask you a question?
Sure.
So to create a new entity, so how much money are you guys putting into what's the initial budget?
So we think, and this is, you can probably all imagine, it's going to be about $10 million over 3 years. And we don't think it's going to cost us $10 million. We think it's going to cost us less if we can kick this off, but we want the 3-year runway to get it going.
What if we had that system today, the one you want to have ready in a year? Completely integrated system for mental health, from scheduling to clinical to payments to insurance.
Are you in sales? That's not the problem. The systems are there. It's the budget. It's getting the budget in place and getting the people who are willing to back the budget.
Very good talk. Thank you. The question is, in the telehealth technology market, there's lots and lots of small companies with new breakthrough technologies who unfortunately are not yet integrated with Epic. And so as you choose your vendors over time, is that Epic integration going to be a kind of a preliminary requirement, or is that something that you plan on working with Epic with after you decide what companies you're going to work with?
No, I think the company would have to be able to be integrated with Epic from the get-go. And the reason for that is, quite frankly, we're so big and we're married to Epic and we're not getting divorced. So as much as a lot of people would wish that would happen, that's not going to happen that I can see. And so it's just not a battle we can take on. It's just one of those, we've got great CIOs and CMIOs in place. And this is just something, we have to work. It's one of our parameters. We just have to work within that system and make sure that whatever products we work with we can integrate with Epic. Oh, yeah, yeah. Yes, if you talk to Epic, they're leading this. Yeah, yeah. They have lots of technology. Yes.
Great, thank you so much.
Thank you. Thank you.